Hey everybody, my name is Carl Bonnet and I am the founder and medical director of Clarisana. So I want to go over one of the most common questions we get for people who are interested in potentially receiving ketamine therapy at one of our centers. And that is, what's the difference between intramuscular and intravenous ketamine, right? Because, the people will say, hey, I see a lot of clinics that do IV. Some of the original studies were all IV. Is IV better? Is IM better? What's this all about? Is there any evidence to support one over the other? So let's talk about this a little bit. There's several reasons why we use intramuscular or what we call IM ketamine. So the first few years of our existence, we actually did IV. Right. So from, my background is I'm an emergency physician and, I've used ketamine for years. And in the emergency department, we do usually start IVs. We'll give IV ketamine, IV anesthetics or whatnot. But the point there is that we're using it in a fundamentally different way. The whole context is completely different. In that regard, what I'm trying to do is have complete control over you. I'm trying to be able to give you a medication that will disconnect your brain from your body and allow me to perform a painful procedure. Now, the set and setting and all that kind of stuff is really not all that important. Really, what we want to do is get you in a place where you don't feel what I'm about to do to you. So that is a fundamentally different situation than what we're trying to do in our clinics at Clarisana. There, the set and the setting is everything, right? We're trying to leverage a non-ordinary state of consciousness in order to help you heal, to help you change your mental paradigm and help you get to a new place where you see things differently. So therefore, the way we approach it is critical. The way we present this, the way what we either put you through or don't put you through is becomes very, very important in that regard. So there's a few things that went into our decision to switch from IV to IM, and there's a few of these same reasons of why I believe that IM is actually not inferior and in many ways better than using IV ketamine. Again, remember the point is we're trying to get ketamine into your bloodstream. All right. Once it's in your bloodstream and doing its thing, it's doing its thing. Right. So the brain doesn't really care or know like, oh, that came in by IV. So I'm going to heal more, or that came in through IM. So I'm going to heal less. But it doesn't care how it got in there, folks. Right. I mean, it just, as long as it's in there and doing its thing, that's what matters. So one of the things too is when we use IM ketamine, intramuscular ketamine, we do two injections separated by about 10 to 15 minutes. So, what that allows us to do is really get you to that place. It gets you to that level of effect where you can really have that transformative transpersonal experience. And the thing is that then happens early on in the first 10 to 15 minutes is where we kind of get to that space. And then you have the whole rest of the session to explore it. When we used to do IV ketamine, well, you set the pump, it starts delivering a certain amount of ketamine every minute, and then you don't peak until 40 minutes, 45 minutes into it, and then that's when you're finally at that point of like, wow, this is cool, and then before you know it, the session's over and it's time to leave. Now I get it, you could program pumps to give a bolus initially and do whatever, but that's going to require very expensive pumps to require staff that really knows what they're doing at a much 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 higher level to perform that kind of ER/ICU level of care, which is going to dramatically change the cost of providing ketamine in that regard, and then ultimately limit access to this therapy. So for most settings, if we're going to use a pretty basic pump, it won't peak until much later. So ketamine, when given IM, it peaks much quicker. Now, the other thing, so number two is the whole concept of missing an IV, right? I mean, even if we have experienced ER nurses working for us who do IVs all the time, right? They still miss. Every once in a while they miss. I mean, it's not uncommon to miss an IV once or twice, so that can really lead to increased anxiety among patients. Where if you have to try starting an IV a couple times and go to the other side, and sometimes you have to find another staff member to give it a try as well. This just happens. This is life. I mean, human anatomy can be challenging, right? And depending on people's physiology and body habits and whatnot, it can pose some problems there. Now that all that does is just increase your anxiety, right? If we're trying to start an IV a bunch of times, then that's not optimal. An intramuscular shot, right? We're basically going to the deltoid, we do it, and that's all there is to it, right? I mean, so it's much quicker, much more effective, and it pretty much going to happen. I mean, I mean, our staff is not going to miss an intramuscular shot. So, anyways, that's number two. Number three is the problem with pump malfunction, right? I mean, an occlusion of the line. If you move your arm, do something in the middle of the infusion, the pump's going to stop. It's going to start beeping, making an annoying noise, all this sort of thing, and then you have to move your arm, restart the pump, do whatever. And that requires having a staff member sitting there monitoring that pump minute by minute the whole time. In order to do that, which again is going to dramatically increase the cost of providing that service and decreasing access to ketamine. So that being said, let's move on to like, well, is it as effective and is it as safe? I mean, some people think, oh, we need to have an IV, like, or else, it's not appropriate. But so let's talk about that a little bit. As far as the effectiveness, right? So our first paper that we published was looking at combat veterans, and that's when we used to do IV therapy with ketamine, and we showed over 90% response rate, which was great. We had 30 veterans, and over 90% of them had a positive response to the ketamine with regards to their symptomatology. We later then did another paper looking at 40 sequential patients of Colorado Medicaid, and then after that, we also then published another paper looking at all the Colorado Medicaid patients that we treated in 2022. All right, uh, so the thing with that is, then those two papers were both intramuscular. The first one was IV. There was no change. I mean, as far as the effectiveness, we still had greater than 90% effectiveness with the two IM papers that we did. Just in communication with a lot of my colleagues around the country, there are a lot of clinics that do intramuscular ketamine and have great success with it as far as the effectiveness. Now, as far as the safety, again, the way we do it is separating the shots in two doses, separated by 10 to 15 minutes. And when we first meet you, the very first session is pretty low, right? Our protocol is to give 1 milligram per kilogram with a maximum of 60, and that's divided into two shots. So I don't want to throw a bunch of numbers at you, but the bottom line is that it's two relatively small doses. So we're going to give, most adults are going to get a 30 milligram dose on their first time, and that's a pretty low dose. So the thing is, we see how you respond. We're able to then adjust our dosing on subsequent visits in a safe fashion, and that's based on us knowing you and how you respond. So when you look at the volumes that we see, when you look at 2022 and 2023, we performed well over 14,000 ketamine sessions in each of those 2 years, and had basically zero ambulance transports. There was nothing, from a safety standpoint, it was extremely safe. There were no adverse reactions as far as airway compromise, any of those things in that 2 year period, with a pretty robust patient volume. So, on the whole, that's why we use IM. If you have more questions about that, feel free to ask us when you talk to our intake team, and we can get you squared away on some answers for that. But I want to make sure you had a little bit of an understanding going into this as to what our thought process is on why we use intramuscular ketamine at Clarisana.